Hi, my name is Kersten. I'm an orthopedic surgeon with EmergeOrtho in the Blue Ridge Region. I specialize in orthopedic sports medicine, specifically the shoulder and knee. And today we're here to talk about shoulder replacements, what they are, what's involved, and what patients can expect. So with a shoulder joint replacement, we're basically resurfacing the ends of the bone. So we've got a humeral head with cartilage on it. We've got a socket on the glenoid with cartilage on it. When those break down and wear out, we are then covering those surfaces with some combination of metal or plastic. There's different forms. We can do a partial shoulder replacement, maybe where we're just replacing the head of the humerus. More commonly, we're doing what's considered a total shoulder replacement, where we're replacing the ball and the socket in one operation. There's also what's considered a reverse shoulder replacement. With the reverse, we're also resurfacing the ball and socket, but it's in a reversed manner. So the glenoid side, or the socket side, gets more of a ball placed, or what we call the glenosphere. And then on the humeral side, we put the cup. So we are changing the anatomy, or reversing the anatomy. And the reason we do this operation is for folks that have usually deficiencies in their rotator cuff function. So the main reason we would need to consider a shoulder replacement, first off, is usually it's pain, it's debilitating patients. A lot of patients come to me with a lot of night pain, so they're having trouble even sleeping through the night because it wakes them up when they roll on that shoulder. As we get more arthritis in the joint, that's the main indication for a shoulder replacement, is an end-stage arthritis that's no longer responding to conservative treatments like therapy or injections or oral medications. We also have some other indications for these replacements, specifically the reverse shoulder replacement. So if we have a patient that has a failed rotator cuff surgery, or they have a rotator cuff tear that's not repairable, we'll look at doing the reverse. If we have somebody with rotator cuff disease in the setting of some arthritis, we consider doing the reverse. We now found that for patients with bad proximal humerus fractures, we're often able to provide better functional outcomes and better pain relief by replacing the shoulder than by trying to keep it with plates and screws. So that's a common indication. And then we're also able to do the reverse in cases where somebody's already had a shoulder replacement with an anatomic shoulder and that fails, or the components go bad, we can revise it to the reverse replacement. So really anybody that's got functional deficits in their shoulder that's failed conservative management can be a candidate for a shoulder replacement. It's relatively low risk in a joint replacement world. I always tell my patients it's less painful than getting your hip or knee replaced in most times, but the therapy is much more intensive. So, with the operation, if they're medically able to handle the procedure, which most can, then it's more a matter of, can you accommodate the PT? Can you participate in the PT? Are you willing to participate in the PT? Wear your sling? And if so, those patients can have a good outcome. So with a shoulder replacement, typically what we do is, it is under full anesthesia. So you come into the hospital or surgery center, anesthesia talks to the patient. You get usually what's considered a nerve block. So they give you a shot at the base of your neck. That takes care of a lot of the pain of the surgery and then allows them to give you a lighter anesthetic. We then sit you up in a position once you're intubated in the room and then do the procedure. Typically we're making about a 6-inch incision at the front of the shoulder. And then we get into the shoulder joint. With the anatomic shoulder replacement, we're putting a metal ball on top of the old ball, so the arthritic bone gets removed with a saw and other instruments. And then we put on a metal ball. On the socket side, we clean up the socket, make it a nice smooth background, and then usually cement in a plastic socket. Then we close the rotator cuff back over the top, because we need a nice healthy rotator cuff with an anatomic shoulder for it to function appropriately. With a reverse replacement, it's very much the same. The setup's the same, the anesthesia is the same, the incision's the same. But in this case, we're putting a metal plate onto the socket that's getting fixed in with screws. And then on top of that metal plate, there's a metallic ball or glenosphere that gets fixed onto that. Then on our humeral side, we're putting a metal stem that's normally about 10 centimeters long, and that contains a little metal tray and a plastic piece that sits into that. So then the plastic articulates with the metal ball in the joint. The surgery for most, it's typically under a 2-hour surgery. For most of my patients, it's about 45 minutes. The nice thing is, the majority of folks are able to go home with the surgery. And usually with the nerve blocks, they feel pretty good afterwards. There's not an intense amount of pain, very little narcotic pain medications required. We do emphasize a lot of icing, anti-inflammatories, and getting into PT soon afterwards are good ways to, address the pain. But, again, as an outpatient surgery, you can expect to come in and go home the same day. Now, there are some patients that require a little bit more medical care after the procedure, so there are times where we'd consider having the patient stay the night after the surgery, but that's fairly rare. So the recovery with the shoulder replacement is a little different based on, again, which implant we do. With the total shoulder replacement, we expect to see better improvements in motion. I always tell patients it functions more like a normal shoulder. We can expect to get the majority of your motion back, reaching overhead, reaching behind the back, reaching out to the side. But we do have to be a lot slower at the beginning of the process because we're relying on the rotator cuff healing back appropriately. So for those patients, we're in a sling for 6 weeks. We're then coming out of the sling and the therapists are progressing the motion, but we're kind of limiting what they're doing for the first 3 months. After that, we're adding in some strengthening. You're doing more things at the gym. I'm usually allowing my patients to start swinging a golf club at 4 or 5 months after the surgery. And the majority of patients by 6 months have full motion and really adequate strength back in their shoulders. With the reverse replacement, it's a little bit quicker. So it's actually even faster than rehab with a rotator cuff surgery. But we're still in a sling 4 to 6 weeks, but after 6 weeks, I don't have to limit patients as much in terms of what they're doing. So it's a really good option sometimes for older patients that may rely on their arms more to use a walker, or they have balance issues and they need to be able to use both arms quicker. We don't have to protect it as rigidly. But with the reverse, it's inherently a more stable implant, but we also don't get as much motion out of it. So the sacrifice is, patients still get a functional motion. They can reach up into their cabinet and get a plate. They can reach out to the side, but reaching behind the back can be limiting. Most patients can get to a pocket or their belt loop, but they're not reaching way up behind the back. They may not be able to reach fully overhead, but again, the trade-off for patients is that they're doing so with much less pain and much better strength than they had going into the procedure. With any joint replacement, there's risks. The risk of infection with open surgery is our main concern. The risk of blood clots with shoulder arthroplasty is much lower than it is in hip and knee surgery. I still like my patients to take some medication to lower that risk, but there is risk of, if you fall on these implants and break your shoulder or break the arm around it, that can create problems and complications. And as not every patient gets their full motion and strength back, or maybe they don't get it back to the level they thought they would. So I think it's important to have that discussion with the doctor and have real clear expectations of what your expectations are and what their expectations are for your outcome, because that also influences sometimes when we're deciding which implant we may consider using. Benefit-wise, I think the main thing is pain relief. Both are very effective pain relievers. The majority of patients wake up from the surgery and the pain they've had from their arthritis is almost gone. The surgical pain itself is very minimal. And so, we expect really tremendous pain relief and then ultimately improvement in range of motion and strength and ability to return back to most activities. With the reverse, there are a little bit more limitations. We like our patients to avoid heavy weightlifting or bodybuilding activities, contact sports, swinging from a monkey bar, but it's okay to swing a pickleball racket or a tennis racket. It's okay to play golf. It's okay to snow ski. It's still okay to exercise. So most people can get back to the things they want. The lifespan of these implants is variable. if we look carefully at the data in the literature, with reverse implants, we're usually seeing about an 85% 15-year survival. So the optimistic view is I tell patients 15 years from the time your implant goes in, there's an 85% chance that implant's still working fine. We do see that the failure rate of the total shoulder arthroplasty is a little bit sooner, so we'll start seeing a little bit earlier failures around 10 years with some of the shoulder implant designs. But at least for the implant I've used, we've got really excellent 10-year outcomes data that, people tend to have good outcomes and limited failures. And again, with a total shoulder replacement, we can revise that to a reverse later on in life if they needed to. So for a joint reconstruction, historically, most of these were done in a hospital setting. In the last, few years and majority of my practice, we've been able to transition a lot of these into an outpatient setting. The benefit for that to patients a lot of times is cost savings. We can do these in a lower cost setting, very safely with no increased risk. Oftentimes we see better outcomes data in patients that go home than we do in the patients that stay the night in the hospital. So I like to reassure patients that you can go home, sleep in your own bed, eat your own food, monitor your own medications, and we can do it very safely with no increased risk, and also save a good deal of money by doing so. So one way that Emerge can offer low cost and high quality care is, we're able to accommodate the patient and what's in their best interest in terms of location. And, from a cost standpoint, if it's amenable, if the patient's healthy enough and we can do these in a surgery center or lower cost center, we're able to do the surgery successfully and well in those locations. And that can offer a 30 to 40%, if not more, cost savings compared to traditional procedures done in a hospital setting. From a quality standpoint, we've got fellowship trained doctors that have trained well in these procedures that are all doing high volumes of these procedures. Myself and others in the practice are often lecturing and teaching other doctors how to do these procedures. So we're able to, do them successfully and quickly and give you the outcome you would want. So if you or a loved one have been dealing with shoulder pain that's getting to a point where you're not able to sleep through the night or it's affecting things you enjoy doing, then definitely seek out one of us at the EmergeOrtho that practices and does these procedures frequently. I do think it's a great option for the right people, and though historically people have concern or they've heard how bad the surgery is, with modern techniques, and these really are great options, and most people are very pleased that they decide to get it done.